Hello and welcome to the Crystal Podcast on iCode Media. Today I had a great conversation with Dr. Kyle Klute. We talked about identity. We talked about who we are as a profession and kind of where we may go as a profession if we really understand who we are. And so in any case, as always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. What Kyle and I are talking about today is the total patient care model. And it really starts with creating the identity and then building a process around that identity that will lead to outcomes. And ultimately, those outcomes are going to be better patient care. And so if you want some help integrating steps, and we believe there's 5 steps to create that pillar, whether it's dry eye or glaucoma or macular degeneration or binocular vision, we have a program that can help you with that. It is a total patient care model, an on-demand program that you can use with your team to sort of workshop these ideas. We lead you through each one of these steps and show you how to build that and allow you to build it for your own team, customized for you. But if you also want some additional help within a mastermind group, we have that available as well. So we're really looking forward to working with you. Thanks for checking it out. You can check it out at iCodeeducation.com, or the links will be in today's show notes. Getting young presbyopes into progressive lenses can be tough, but it doesn't have to be. Verilux Liberty 3.0 lenses are an introductory solution for new and young presbyopes, and they are available in select ad powers. This lens provides all-in-one balanced vision for an accessible and great first-time progressive lens wearing experience. Learn more about Verilux Liberty 3.0 lenses and get free resources to help start the progressive lens conversation with young presbyopes at eslorpro.com/Verilux. I want to get your perspective on the problem. Like, the problem in most primary care optometric practices is what?
The problem, let me share a story first that I think highlights the problem, that because I don't want to say the problem too bluntly and sound unempathetic and people be turned away by it. So
well, I think, but
go ahead.
And let's preface that too, because I think it's important to kind of work through the fact, kind of the background of people that listen to this, that have seen you on the podcast before, know that you and I spend at least an hour a week with our minds sort of open to different ideas, to challenge each other and to kind of explore ideas in a space that's kind of sounds weird, but like a non-judgy space. And most of that comes down to like public health types of things and optometric practice.
Yep.
And so we make these observations about what we see ourselves doing, and what we see as a natural tendency within our profession and within ourselves, and also reflecting on our peers and how we see those same natural tendencies among them as well. Mm-hmm. And so I think I'll kind of set it up to say, I know I haven't asked you what that question is or what the problem is, and we haven't talked about what your answer is going to be. I don't know exactly. Yeah. But I kind of know. And so that's sort of the facetiousness of this. But it's also the fact that it's not you, when you set up the problem, it's not you being judgy, although it could come off that way. It's that we are optometrists. We see a natural tendency of ourselves, and we're really connected with a lot of our peers to see the same thing among them. So go ahead. I wanted to set that up so it doesn't sound sort of wrong.
Great preface. Sets the context well. So I would say it has to do with the word just that single word just. And what I mean by that is that when I was in residency, so I did a residency, a VA residency in Battle Creek, Michigan. And one of the things that my residency director, Dr. Molly McGinty, she was really good about kind of poking fun in a good way, like in a way that built you up and corrected you, but also made you aware of like, hey, this is kind of your wrong thing right here. You need to kind of correct that. You need to value yourself more. And what she would do is she would hear you saying to patients the statement, hey, for example, you'd be walking down the hall, you'd be bringing, you grab your patient, you walk down the hall with them, and then you take them to your exam lane. And they would ask you a lot of times, "Hey, are you an eye doctor, or what is your position?" "Yeah, and I'm an optometrist." "So do you do surgery, or are you an ophthalmologist?" And a lot of times, what I would find myself saying, and what Molly would catch me on, is I would say, "No, I'm just an optometrist," and and it would just make her.
You would never hear an ophthalmologist say that, by the
You would
way.
never hear them say that. So it's the word "just." That's what she would pick apart. That's what she would hear you say, and just make her skin crawl. And then she would kind of joke with you, "Just an optometrist, huh, Kyle? We're just optometry." And I know that that's kind of joking, but that phrase gets underneath, I think, a lot of some of the perils or some of the issues that we constantly struggle with in our profession. Of we Too often we think that we are just like it sounds, we're just an optometrist. The opposite of that is like, hey, we're an optometrist. I'm an optometrist, and this is what I do, and I have a very clear identity of what I do and how I do it, and I have a really strong belief in my abilities and how I can help patients and what I do to help the community through my skills and expertise in eye care. That's different than, well, I'm just an optometrist, because it kind of positions you, it creates a mindset or like a fundamental belief structure that you are subservient to something else, that you are just kind of like, I'm nothing against our PA, like physician assistant counterparts, but I wonder sometimes if our schools aren't doing a good enough job educating our optometrists. They're creating mindsets that they're subservient to ophthalmology, and they're not, like, we're not our own distinct profession. We're not experts in eye care to be ophthalmology assistants, right? And I know that's kind of extreme and a little bit crude, a little bit blunt, but like, we are who we are. Like, we are a separate field, and we're a profession that knows how to take care of the whole patient. And we are the best place for patients to go for their eye care. So it's a really like robust identity issue that I think underlies a lot of the ailments of our profession.
Well, I mean, it certainly encapsulates a lot of the conversations we have, and mostly it's why do we do this? Why do we do this as optometrists? And the thing that one of your mentors and mine, yours in a lot of ways clinically, mine in a lot of ways legislatively, but Bob Vandervoort, he always says, optometry is not a subset of ophthalmology. Optometry is not a, we're not a, and actually, to say it another way, ophthalmology doesn't, and we all know this, but ophthalmology isn't a next level optometrist, right? So that when they come and try to compare themselves to us and compare their education to our education, etc., it's just not a comparison that they know anything about, and also that is an accurate comparison, and but it's obviously exploited. So I want to get into this because it's easy to blame like one thing. We've done it. We've blamed probably everything on why this happens. But we see the same thing. Is like we see that well, I'll just let the glaucoma surgeon take a look at this patient, or we'll kind of hedge. Well, here I see a retinal hemorrhage in the back of your eye, and I have a doctor I respect a lot, and I've gotten to know him pretty well over the last few years. And just how does it sound when you see a blot hemorrhage in a patient who doesn't have known microvascular risk factors? And sometimes you can kind of see him kind of wiggling as we talk through some of these things. See him wiggling into this well, you could just see the retinal specialist, like talking to the patient. Well, we don't know exactly what this could be. It could be, he knows exactly what it could be. It could be high blood pressure. It could be Valsalva. It could be diabetes. It could be high cholesterol, or it could be this whole other kind of these zebra kind of conditions that could cause these little hemorrhages. And so I want you to see your primary care doctor, talk to him about that, right? And then almost kind of leave himself out with the patient of like, well, we could send you to the retinologist. We and my question always is when that happens is, and it's not just to him, but it's to everybody. It's like, well, what are they going to do? What are they going to do? And if you can't answer that, you need to figure out why you can't answer it. Mm-hmm. And if you can answer it and it's the same thing that you can do, then we need to be able to do that.
Yeah, for sure. How do you think, how do you, Chris, how have you arrived at that for yourself? When you look at it, we just discussed, fundamentally, it's an identity issue. When we think about it, when we think about optometry and having that little bit of a mindset issue of being just an optometrist and maybe not feeling like maybe they're trained well enough to handle certain situations, or maybe not believe that they have the experience to handle it, or maybe just not, like you just referenced to, maybe they don't even know what to do. Maybe it is purely just understanding or knowledge of the situation at hand. How did you arrive at that? You're clearly in a position where you have practiced in a way that is taking care of the whole patient for over a decade now. What got you there?
I think I think as you've described really well, and I didn't arrive at this, but it's identity. I mean, I would have been able to answer this question 7 or 8 months ago before you and I had talked about it on one of our many runs. But I think it's identity, and actually it is a belief that I am better than, I believe our profession is better at taking care of the whole patient than our counterparts. If push comes to shove, I think that's a belief I have. And that belief was instilled, by guys who kind of, who I was able to rub shoulders with and who were able to kind of bring me through my growth in both clinical aspects and also political aspects of the profession. So I saw how they practiced. I saw that, well, they don't need to be just an optometrist. They are an optometrist, and they embrace that. And so guys like David Cockrell, guys like my dad, guys like Bob Vandervoort, and guys like Jason Ellen. Jason was one of my, I've started talking about it. It's that they instilled in me a belief that we are better. And maybe better is the wrong term, because then some people kind of recoil at that. I make this joke often now when I speak, but it's like, well, no, that's kind of arrogant. I don't believe it's arrogant. I think the profession has demonstrated over years and decades that we provide excellent care. And part of why we provide excellent care is because we're very reflective. And when I say that that's how I practice, and you made that comment about taking care of the whole patient, it can come off really arrogant of like, no, I'm better than an ophthalmologist. And I think the reason we're better is not necessarily because our technical skills are better or our diagnostic skills are better or our ability to manage uncertainty is better. The reason we're better is because we have a healthy skepticism of our own place in the world and our own place of like what we know and what we don't know. And unfortunately, that skepticism of what we know for certain and what we don't know for certain, that is that's the question that I asked you. And that's kind of your answer too, is like, if you don't have a good handle on how to manage that, then it's really challenging. And I've just had good mentors to help me manage that. So it helps build confidence. So I think the point is that what makes us better as a profession is that we understand, we have humility to know that we don't know everything. And I completely think that about myself. I don't know everything. But where I feel like we can master this as a profession hopefully better over time, is instead of that uncertainty creating doubt and kind of fear and just this, just an optometrist, it creates a situation of like, all right, well, how do I navigate that uncertainty and be able to know that, I was trained in the same way that everybody else was. And I know that in me is this sense of like, well, maybe I'm wrong, but how do I hold on to that maybe I'm wrong mentality in a way that helps patients and doesn't just make me kick them off to somebody else? And that's I don't know if that's the best answer I could give you, or even a clear, direct answer, but it's kind of what I would think as why I'm the way I am.
Yeah. And I mean, people see, to even get more personal with you, like, I think people see you as as such a high achiever. When we look at what you've accomplished, and this isn't a podcast about you, Chris, but I'm just using this as an example. Like, when you think about the things that you've achieved in your career so far, you have a thriving practice with 2 associate optometrists helping you out, and you've got 9 children and a wife to take care of. You've got a successful podcast. You're instrumental in local and federal legislative issues for the profession. You lecture all over the country. And I think a lot of people can see that as, holy smokes, how does he get all that done? And I've grown to understand you better, just through our friendship the last several years. But it hits on the point, like when it comes down to it, the achievement that you've been able to do and over the many course of the years, it's because of a fundamental way that you believe about yourself, and if you were to define, that whole encompassing thing, I'm guessing somewhere along the lines, like you believe that you can do all those things. Like you have a high, you obviously are an achiever. Your personality is, you're gifted in a specific way that you're fairly effective and fairly efficient what you do. Like that's a non-negotiable, but even beyond that, people can be really effective and efficient, but if they don't believe in themselves, if they don't believe in what they're doing and have a identity based upon a really purposeful why, right? They're still not going to achieve what you're achieving and what you can achieve, So it comes back to like all this, what we're pointing to. There's, and we've talked about it so much, and I've included in some of the lectures I've given the last year, but one of the best books in the last, I don't even know, 3-4 years, I think it was released in maybe 19 or so, 2018 or 19, is James Clear's Atomic Habits. And I actually got to kind of have a little bit of a review. The book is on my list, my to reread list for this year. But also Tim Ferriss just had James Clear on his podcast this week, which was a great refresher. So if you're listening to this and you need a good refresher from the author, go and listen to Tim Ferriss, the Tim Ferriss podcast. It's a fantastic interview. And James Clear, he goes through so many different things about habits. But one of his big things about creating sustainable habits is you start with the identity. And that's really what we're talking about, right? So we always think of a habit or goals or achievement. We want to start with kind of the end in mind. And that's okay. You can do that. We want to start with like I want to lose 20 pounds. We start with the actions that are going to take us to losing 20 pounds. And then we get really regimented and in trying to achieve those things. And then a lot of times maybe we'll achieve it. And if we do achieve it and we succeed, well, a lot of times that weight comes back because we get burned out of achieving, right? What James Clear makes clear, no pun intended, in his book is he talks about how when you create a new habit, you have to start, or it's better to start with the why first, or with the belief first, because or the identity first. So in that example of losing weight, basically if you want to lose 20 pounds, it's better to start with the idea of, you know what, I want to be the type of person that can run 2 miles a day. Or I want to be the type of person that is really fit. Or I want to be the type of person that can do, 50 push-ups. You start with an identity first, and then you create the actions to reinforce the identity. because and that's the genius of that concept is, and I think it's so true, is that the identity determines action, or identity or beliefs underlie action, and then actions reinforce that identity. And so the reason I find that so powerful is because I look at that in my practice, and I'm not one that just like, by nature, I'm not super effective and super efficient. I'm actually quite passive. I'm pretty introverted. It takes a lot of work for me. It takes a lot of structure for me to be assertive. And you probably, we're pretty opposite in terms of our personality. I mean, there's sometimes when you're very assertive, I'm more responsive. There's probably times when in our, friendship, when you're probably like, holy smokes, Kyle, just make a move, like make a decision, move forward. And then there's times when I'm looking at you and I'm thinking, Chris, come on, slow down, buddy. Like, just like think through this, but that's just personality wise. So I personally just need, I've always been, once I realize these kind of things about myself and become aware, like I know that it's really important for me to always focus on the why and the identity first. And that's why it's been so important in my practice as it's grown. We started about 3 years ago. I bought a practice, kind of a warm start practice, and kind of reinforced these types of things with my staff and with our protocols from day one. And it all comes back to like, okay, I'm the type of optometrist that takes care of the whole patient. It started with that. I'm the type of person that does this. I'm the type of optometrist that can do myopia control and treat glaucoma and take care of a retinal tear and refer appropriately and also diagnose binocular vision disorders, and then you build the actions to reinforce that identity as you go. So I love that concept. It's been super helpful for me.
Yeah, I think I agree with you. I think there's some things about your analysis of kind of your personality. I think you have a better handle on your identity or your personality than I might. And I think, and actually, I try to find I think I may have some blind spots that you've been able to help me a lot with, of like, being able to identify that not everybody thinks the way I think. And that's been really helpful. And actually, like, by knowing that, it can help me. Again, it's just in general, if you've been able to identify, be able to pinpoint your identity, it can really help you be more effective when you do realize that everybody doesn't think the way you think. And how can you effectively communicate with people who don't think the way you think? And actually, what all of this builds to is, I was reflecting on this the other day. So I was, I've talked about F3. You're an F3.
I am, yes.
But I can't get you back again to get to a workout. But I think the reason I bring that up is I was talking yesterday. I was running at a site called The Catalyst, where we run on Old Lincoln Highway with all those cobblestone.
Yeah. So Chris,
brick.
Add that to your list of things that you achieve on F3 every morning.
Yeah. So the reason I bring this up is I was, your kind of bringing Atomic Habits to me was like a moment of really great clarity in my ability to kind of pinpoint things about myself, and also help me and kind of help me through just reflection with you over the years of understanding how to communicate with other people. But the reason I bring this up is I've got there's a guy in F3 who I am just pulling for. I mean, just pulling for so much, and I like and a lot of guys are. They've got so much vested in this one individual, and he's made these great strides over the last 5 to 6 months, and then you see this, and then kind of this falling off the wagon. And I was talking to another one of my friends about it in the group, and he was asking me how this guy was doing, and we were kind of reflecting on it, and say, hey, reach out to him again, see how he's doing, kind of bring him back along, and and we're kind of reflecting, like, why is he having trouble right now? And what it occurred to me was like, it's the opposite. Like you ask me, well, how do you do people ask me, like, how do you do all this stuff? How do you manage the time and do all this stuff? And it's like, I don't know. I just do it. You kind of get in the habits. But I bring that up because imagine that it was completely the opposite. You had a hard time waking up in the morning because you just didn't feel good about yourself and you didn't have good fundamental beliefs, and you create these processes in life that ultimately have road bumps, and those road bumps, you can't overcome them. And so you never achieve the outcome you were looking for. So you feel like you're a failure. Like it's totally the opposite, and how hard that would be to overcome those things. So I was like, well, look, if you came to me and said, Chris, this is all wrong. Like the way you're living your life is all wrong. And I had this like built-in identity. And then it was totally wrong. I'd be like, well, no, it's not. And how hard it would be to kind of reverse that ship. And so it just speaks to the larger aspect of kind of us as an individual, not even just within optometry, but, with him, he's trying to not just kind of enhance the way he feels about himself. Like you and I get to say, I'm kind of really good at this one thing. And, maybe if I figure out how to have a better identity, or be the type of guy that can do this, it's like, I'm not the kind of guy that can do that. It's really hard for me. I'm 50 pounds overweight, and, my wife left me. I don't have a great relationship with my kids. And, like, I'm not saying that's him. I'm just saying, like, whatever that thing is, it just sort of beats you down.
Yeah.
I mean, we talk about being a man and like, as a man, that's what I know. As a man, that would be so defeating. But I guess the point is that as I reflect on that, if as a profession, we haven't done a job of really kind of pinpointing our identity and having this firm rooted belief in our identity, then you can see how we can just be like, I'm just an optometrist. So today I want to talk about the MyDay multifocal for just a second. It has been a really great thing in our practice for our patients who are presbyopes of all areas, but those tricky presbyopes are always the ones that are kind of emerging, where they don't want to give up any of their faraway vision, but they're having some struggles up close. And so what the MyDay multifocal has been able to do for us is to allow those patients to transition into a multifocal more easily. And then as we have those patients progress into other levels where they need more ad powers, it's been a nice smooth transition. So the ultimate hurdle that we've seen in our practice before the MyDay multifocal was that we'd have patients who would resist any transition to a multifocal lens because of that distance blur. We just haven't seen that. So if you haven't started using MyDay multifocal in your practice, I would encourage you to start, check it out, reach out to your Cooper reps for those trial lenses, and commit to MyDay multifocal for your patients. I think they're going to like it. If you haven't checked out MacuHealth yet for your patients in Category 1 through Category 4, I think there's a lot of evidence that you should be considering. The first is, if we just look at AREDS 2 and what they talk about, MacuHealth is, so for patients in Category 3 and Category 4 AMD, MacuHealth is a great option for them that follows that entire protocol, and it also adds mesozeaxanthine to the mix, which, if you look at some of the evidence, I believe shows me that it's going to thicken the macular pigment better than without mesozeaxanthine. It also uses the correct AREDS 2 dose of zinc at 25 milligrams, and so you don't have to worry so much about the potential side effects of zinc. The other thing to think about, and it's beyond the scope of this, although you've probably heard me talk on other podcasts, is that in patients in Category 1 and 2, there may be some additional benefit to supplementing them with something that may be a little bit less than the AREDS 2, so you don't have to add as much to it. And that's where I use the MacuHealth LMZ3. And so I think if you haven't done this yet, I'd consider MacuHealth in your practice and for your patients. And it's been great for my patients, and we really feel like we can have the ability to help those patients in all categories of macular degeneration.
Yeah, a couple points to that. I think when you look at that, like when you think about that scenario of your friend there, and you kind of realize and reflect on how hard it is actually to change identity, I think that that speaks to That speaks to the power of community, right? Um, I think that as I've reflected on this kind of that concept of like identity determines action and an action reinforces identity, it's like, well, what if you just look at successful people, and a lot of times identity isn't chosen first, but they still become successful and they still become like habitually successful. So you think, well, why is that? And I think the reason is because of community. If you because you can catch actions from other people, you can catch habits from other people, and I think that's by and large what we caught from like the list of guys that you talked about or mentors, and I have a list as well in my mind of things like actions and habits that I caught that kind of like
Mm.
in a back-ended way reinforced, like created the identity of who I was. Um,
Hmm.
and I think community really does that. It reinforces that identity. But if you're on your own, like if you don't have a community around you, like you have to start with the identity, and then you probably have to find a community of like-minded individuals that can reinforce that and then can keep you accountable to those actions. You know, the other thing, and I think that pertains to our profession tremendously. Like, we're not here to promote any specific, like vision source or anything. We're both part of it, but the big part of really the primary reason why I'm part of it is because of that community aspect of it. When I
Yeah.
look around, I just see really, really good optometrists doing what I want to do, have successful practices, and a lot of them are part of this group. So it's like, well, I want to be in the same room as them, and I want to, if I go through troubles, I want to be in the same room with them. If they go through troubles, I want to be in the same room with them, and go through and understand and promote our practices and figure out, the next technology and treatments and protocols. So I think that's the power of community. The other thing as it pertains to our profession, like I'm just going to read you. This is a slide that I've presented in the past that it's called "What is Primary Eye Care?" And I'm going to read this list of bullet points, and then I'll tell you where it's from. So this is the definition of primary eye care in one of the clinical guidelines that's out there in our profession or in our industry. It's educating patients about maintaining and promoting healthy vision. It's performing a comprehensive examination of the visual system, screening for eye diseases and conditions affecting vision that may be asymptomatic, recognizing ocular manifestations of systemic diseases and systemic effects of ocular medications, making a differential diagnosis and definitive diagnosis for any detected abnormalities, performing refractions, fitting and prescribing optical aids such as glasses and contact lenses, deciding on a treatment plan and treating patients' eye care needs with appropriate therapy, counseling and educating patients about their eye disease conditions, recognizing and managing local and systemic effects of drug therapy. There's two more, hang with me. Determining when to triage patients for more specialized care and referring to specialists as needed and appropriate, coordinating care with other physicians involved in the patient's overall medical management. The last bullet is performing surgery when necessary. This is the definition of
That's ASCO.
This is the definition of primary eye care from the preferred practice patterns. Or actually, it's according to the Academy of Ophthalmology.
Academy of Ophthalmology. Well, yeah, and actually, ASCO's statement is very similar to that. So the Association of Schools and Colleges kind of have they call them attributes of graduating,
Hmm.
of graduating optometrists, but it almost mirrors that
Hmm.
of what primary care
Yeah.
is for ophthalmology.
So I just think if there's any identity, like if there's one like take home to this, obviously it's know your beliefs, know your why, but also it's we're primary eye care physicians. Like that's and we're the type of doctors, or we believe we are primary eye care physicians. We're the type of doctors who do this, and it's that entire list, and we do it all. We do it all for for the visual system, for the eyeball. So uh, again, it takes community. It takes all of us to kind of rally around this concept and understand where we don't maybe fundamentally believe that. I think that's one thing too. Is I think uh, a lot of people, if they haven't really thought this way, if you haven't really thought about what beliefs are underlying your actions, it's kind of hard to. Those are some tough questions, some tough, actually really just tough answers to find, or tough questions to find answers to. But it is really important, not just as your own individual, or kind of your own, your own career path and all that, but it's really just important as you just treat your patients and build your practice.
So I'm going to stop this here because actually you and I have some other things we can talk about related to that. And I think this is a really great stopping point for that. So if you're interested in thinking about how to ask the why and then build processes around that why related to managing patients in a primary care setting, because there's a lot of nuances that you just unwrapped there, Kyle. And I think let's take another episode to do that. So we'll plan for next week. Stay tuned for next week. And Dr. Klute and I are going to talk about the way to sort of create processes around that identity so that you can fulfill that identity and provide the outcomes that you want within your practice that will ultimately reinforce that identity and take you to the next process. So Kyle, thanks for being on today.
Yeah, thank you.
Appreciate it.
Appreciate it. This was fun.
You're welcome.
We'll see you next time.
It was a lot of fun.